So what we're going to talk about today is sort of rapid fire, some sort of highlights in Peds, things that the point of this lecture, I guess, is to empower you all to do sort of what you wanted to do anyway, but you may feel pressure by the patients or feel like, oh, I should order this test or not. And I'm going to follow the Choosing Wisely campaign from ACEP. This article was, I have the citation here, it was just recently published a few months ago. And a bunch of experts got together and said, okay, what are the top 5 that we can really recommend reducing ordering of tests or imaging that are sort of high cost, low value items that don't really add to our practice. And I hope this really encourages and empowers you to not order that study. Sometimes patients want it, but you can cite this article and cite the supporting literature showing, okay, listen, this isn't going to really make a difference. But it also helps you with your throughput time, and hopefully, will encourage you. Okay, yeah, I can get this patient. I can assess this patient clinically, and I don't have to rely on these really sort of low yield tests. The first is avoiding chest x-rays in kids. So now we talked, if you were at the imaging boot camp, we talked about chest x-rays. It's actually not that much radiation for some information. So certainly if you're kind of on the fence, it's okay to get it. It's equivalent to about a transatlantic flight. So if you fly from New York to London, or even from LA to New York, that's about just one time is about 2 chest x-rays, not quite 2 chest x-rays. So it's not that much radiation, but it does take time to get the study. I mean, especially in my department, my goodness, sometimes it can take hours in that radiology queue, and then to get it up and then get it read, it can take a while. So this recommendation is just to empower us that we don't have to get this chest x-ray in an uncomplicated asthma patient, especially patients with chronic asthma. I mean, that's a lot of images over time. Bronchiolitis is a clinical diagnosis. You don't need an x-ray unless the diagnosis is unclear. Croup, not helpful. We talked about that as well. You can have a steeple sign on a normal kid. And first-time wheezing, do a clinical assessment, but it's really not necessary, so you don't need to do that. The next up is avoiding routine screening labs, and a lot of my colleagues at LA County did great studies, really important on this, avoiding routine screening labs for pediatric psych patients. We all know these kids are previously healthy. There's a really low yield. So if that's required by your institution or accepting facilities, please, there's a lot of resources supporting just the yield is very, very low. It's unnecessary. It's expensive. It's we don't need that. You can medically clear patients based on your history and physical exam. One pitfall that I will just add in there, and I have this conversation with my residents when we have sometimes we're boarding like 16 psychiatric holds in our ED. It's sort of ridiculous. But the one pitfall, our job is to make sure that these patients don't have anything medical. And I always remind everybody that Tylenol is completely asymptomatic, it's potentially fatal, and we have an antidote to it. So for me, that's a can't miss diagnosis. So that's the group, so the kid that is acting out in school and had an outburst and then gets on a hold and comes to the ED, I'm not going to check labs on that patient. I'm not worried about an ingestion, or if they're in settings where they don't have exposure. But if this is a teenager who's had prior attempts and who has had ingestions in the past, if they're truly suicidal, they're not going to tell me that they took something, right? So I'm going to have a lower threshold in that group. That's sort of the one exception. And obviously, if they have some medical condition, like they're diabetic, please make sure that they're not in DKA or have any medical treatment that needs to be treated. The next thing is to encourage us and empower us. Like, we don't need to get strep testing in kids under 3. It's very uncommon unless they have like a known exposure sibling with strep. The sore throat in a kid, the vast majority of the time is a viral infection. And actually, even strep in kids doesn't really present with sore throat. It's more like fever and congestion. So you don't need to, please don't get it routinely and feel empowered. You can call it a virus infection. It most likely is. Next thing is avoiding IVs in kids that are sort of dehydrated. My colleague and I wrote a review. It was really interesting on dehydration in kids, and it was kind of fun to look at the literature. I mean, when I was in training, there was pediatricians that were like, "Oh, I can tell they are 17.5% dehydrated." And looking at the literature, even long story short, nobody is very good at assessing what percentage dehydrated. You can tell. I mean, they really dehydrated, not very dehydrated. It's hard to tell clinically. That said, virtually all amount of dehydration, you are able to rehydrate orally. So feel empowered. If you avoid an IV in a dehydrated kid, well, man, the nurses are happy, the kid's happy, it's a win-win. You can rehydrate any amount of dehydration orally. But it takes some, especially if they're significantly, moderately dehydrated, it does take sort of intention, and you have to be there. With parents, I sometimes will hand them a syringe or a teaspoon. I say, okay, listen, 5 cc's every 1 to 2 minutes. It's pretty aggressive if they are significantly dehydrated. I added this comment as well. Don't forget about the NG tube. So super dehydrated sick kids, if you maybe you want to get an IV on that patient, which is reasonable, but you can't get great access, you can use an NG tube. Now, it's not very comfortable, but that is an option too. You can while you're trying to get access attempts, don't forget about the NG tube. Now, it's ideal to have a nice balanced solution like something like Pedialyte because that will keep your electrolytes stable. That said, most of the time it probably doesn't matter, especially for the kids that are more mildly dehydrated. And there was one big study showing that dilute apple juice was the most palatable, and it's not an ideal solution, but you give them what they will drink, especially if they're eating a little food. The oral rehydration solution matters less. So rehydrate them. Parents love to have numbers. So here's some numbers you really want to, if they're dehydrated, rehydrate them 50 to 100 cc's per kilogram initially. And then if they have vomiting or diarrhea, I just give them this number I will write down every time they vomit, give them this amount, or every time they have an episode of diarrhea, give them this amount. So technically probably 5 cc's per kilo for every vomiting episode and 10 cc's per kilo for every diarrhea episode. I sometimes keep it simple and just say 10 cc's per kilo for every episode. Next recommendation is to avoid CT scans in minor head injury. And this is so important. So we see a lot of head trauma in kids. And the PCARN really utilize this. This is a fantastic resource. And I hope that you use this to empower you to really reduce scans. So I quoted an article here that I reviewed for a sort of best practices, highlighting some key papers in 2023 for the care of kids. And this was fascinating. This study here was a multi-center European study, and it's the best looking at sort of outcomes with radiation in young adults. They actually looked at patients who received a CAT scan 25 years and younger, so when they were sort of a child or young adult. And it was a very rigorous study. And they looked at and they said, basically they concluded that one person will get brain cancer for every 10,000 scans ordered. You think, okay, that's not terrible, right? But then you think about the reality that we get about 5 million scans in the US every year. That's 100 people get brain cancer every single year. And a lot of those scans, sometimes they're necessary, but a lot of those scans are unnecessary. And I think a big area of potentially unnecessary testing is pediatric scans. So please utilize PCARN. Look for the risk factors. Now, just because they fall out of PCARN, they have, episodes of vomiting or the mechanism is bad, just because they fall out doesn't mean that you have to scan them. Observation is a reasonable alternative. And obsing patients, and having that conversation. So use all of those amazing tools from Diane. When you sit down and talk with parents and say, okay, tell me about your concerns. It's you take the fight out. And I always, I start my conversation, especially if parents really want a CT scan for their kid. I take the battle out and I say, if you really, really feel strongly and want that CT scan, we'll get it. So then it's not about me versus them. And then I step aside and I say, okay, now tell me about your concerns. And I really listen to their concerns. And then I'm like, okay, I hear you. You know what? I'm with you. I devoted my career to taking care of kids. I don't want to miss a bleed in your child's head either. That would be devastating. That's not why I'm here. But after you've heard their concerns, let me tell you about why I don't want to do this. And I don't want to do this. Actually, it would be easier for me to order the scan. But I made a commitment when I decided to go into medicine. I'm going to advocate for your child. And even though it would be easier for me to order it and medical legally, maybe it'd be safer. But it's not the right thing to do because I don't want to expose your kid to this unnecessary radiation. And usually kids are like smiling and talking, like, look at your child. Like, no surgeon is going to take that child to the operating room, even if they had, God forbid, had a little bit of a bleed. Usually they just even a small subdural. So I have that conversation, and I've never in 20 years had a patient and said, after that conversation said, yes, I want to do the scan anyway, except for like weird social dynamics. And I'm like, I wouldn't feel bad about getting the scan because I'm like, what's going on at home? But most of the time parents, really are responsive to that conversation. The next thing is just to empower you that you don't need labs and imaging in most pediatric seizures. Again, as long as they're looking okay. Of course, the continuously altered patient who doesn't look right, or, weird story, please, pursue labs and imaging in that patient. I'm talking about the first-time seizure, a kid who looks great, who's back at baseline, neurologically normal. We do not have to get any labs or imaging in the ED. Again, this is the consensus recommendation. Kids have a lower threshold to seize than adults, and more than half the time, they don't have a recurrent seizure, so they can do an outpatient workup. Again, MRI is better than a CT anyway. I'll give you a lot more information. And this is afebrile seizures. Febrile seizures, they don't need anything even as an outpatient. Simple febrile seizures, as long as they look okay. Next, we talked about this in the imaging pre-course, void KUB for constipation. It doesn't tell us very much. It's neither sensitive nor specific, so not very helpful. Don't use this just to diagnose constipation. Really what we care about is fecal impaction, and that's not going to help you on KUB either. Be empowered to not order this expensive viral panel testing. For years, working at the county hospital, we didn't even have that as an option. And then during the pandemic, we did have it as an option, and it was tempting, to get it a little bit. But these tests are expensive. And they test for what the top, 19 viruses out there. Well, maybe this is virus number 2021. They still could have a virus infection, just not included in the panel. And we all know the pearls, or the peril and pitfalls of this test. So it's very well described. You can have multiple viral infections at the same time. You can also have a viral infection plus a bacterial infection, or it could be positive and that's not even the cause of their symptoms. So don't feel the need to order this. It's not going to change your management. We talked at length yesterday about labs in kids. So after 2 months of life, trust your clinical experience and expertise. You don't need to routinely get labs. And this picture just makes me happy. This is my twins when they were 13 years ago. So they're so fun, very happy. Okay, and then also, we've known this for a long time, blood cultures, not as helpful as CMS would lead us to believe, but especially in kids, if they are non-toxic, otherwise okay with pneumonia, you don't have to routinely get blood cultures. Next up, headaches in kids. So you will see a lot of headaches. The vast majority of headaches in children are benign. They're self-limited. They are really easily resolved with acetaminophen or ibuprofen. But please do a thorough neurologic exam. This cannot be understated. So the vast majority, I mean, every once in a while there are brain tumors that come in, of course, meningitis, pseudotumor and cerebral venous sinus thrombosis both of these diagnoses can be subtle. So have it on your radar, ask the right questions, ask for, flashing vision changes, flashes, lights, and then perform a thorough neuro exam, including looking for papilledema. Sometimes in kids, it's hard to assess for papilledema. I love ultrasound. I'm taking a look. Of course, we don't have great cutoffs for kids, what is normal, but looking at the optic nerve diameter, you can, it just is another data point. If I'm kind of worried about this patient, it looks like they have papilledema, that's another data point I take. They've got a concerning history, and then I pursue imaging. I've had 2 patients with brain tumors that have had the only neurologic deficit that they had. Again, vast majority of brain tumors do have something abnormal on their neuro exam, but 2 patients only had visual field cuts. That was the only thing. So include visual field testing in your neurologic exam. Okay, avoid delays in epi and anaphylaxis. So if you think that this could be anaphylaxis, please give epinephrine, especially in kids. They can handle it really, really well. And remember, so yes, a rash, urticaria, we think, okay, this is an allergic phenomenon. If we've got swollen lips, respiratory distress, we think anaphylaxis. But 20% of patients can have 0 skin findings. But you can also have, dizziness, nausea, vomiting, diarrhea. I had a patient a few years ago who had known shrimp allergy and came in with vomiting and diarrhea and felt super dizzy. He's like, oh, I can't really stand up, can't really walk. Had no rash, no respiratory symptoms, and he had known shrimp allergy, and he said, oh, I had some soup I think had shrimp in it. And we gave him epinephrine. My nurses were like, oh, Dr. Rose, I trust you, but why are you giving food poisoning epinephrine? I'm like, okay, academic. But we gave him epinephrine, and it was great. He was like Diane in the bathroom. He was dancing around the emergency department. He was very happy. We treated the anaphylaxis. And delay in treatment does worsen your outcomes. So epi is really the treatment for anaphylaxis. We give antihistamines, we give steroids because it makes sense physiologically, but that's not really the treatment. Those things take a long time to work. And antihistamines really only prevent further release of histamine. They don't do anything with the histamine that's already circulating. So remember epi. And I like to remember, because I can't do math in my head when somebody's sick in front of me. I don't like to put myself in that situation. I remember the 0.15 and the 0.3, the EpiPen Junior and the EpiPen dosing, and I can give that and even repeat it just when I'm in a pinch. You don't have to perform a chest x-ray in a neonatal fever if they don't have respiratory symptoms. That's another thing that we can reduce. And C-spine imaging, speaking of exposing kids to unnecessary radiation, I could talk about this for a very long time. So C-spine injuries in kids. On one hand, we'd never want to miss an injury. So certainly if this kid was ejected from a high-speed motor vehicle accident, please image that. We could talk for a while, what's the best imaging? Honestly, MRI is the best. So you could, leave them in a collar and get an MRI. That's absolutely reasonable. But we do a lot of unnecessary imaging of pediatric C-spine. That's a lot of radiation. That's just not necessary. So please utilize a rule. Try to clear these kids clinically. You can really, sometimes if you can't tell if the kid's crying, you can't really assess them, just leave them in the collar. And then later on, once parents are there, have them try to sit up on their own. Try to clear these kids clinically, because the incidence of C-spine injuries is relatively low, especially if the mechanism isn't there. You can be reassured by that. So the Canadian C-spine rules didn't even include kids. Nexus did, but in their big database of like 10,000 plus patients, they had very few C-spine injuries, very few pediatric C-spine injuries. even under 8, and they had 0 under 2 years of age. That's just a statement of how rare these injuries are. So more minor mechanisms, please try to clear kids clinically. So apply Nexus if you can. I love it, especially for that toddler that comes in strapped in a backboard. I will have an idea based on my pre-test concern, based on mechanism. I'll take a look at them. If they don't have evidence of head trauma and they're alert talking, if they're on the board and looking like this anyway, I'm like, oh, they've just cleared themselves. But I will often just unstrap them and then have mom or dad hold out their arms. If they can sit up on their own, I'm like, okay, they're clear. If I've kind of done a general assessment, like, okay, they don't have a lot of injury. Here's an algorithm that was included in my textbook on pediatric emergencies. You can use that if you find that helpful. The next recommendation is about bruits. You don't have to admit low-risk bruits, and let's just briefly talk about what a bruit is. Bruit or brew, I don't know, tomato, tomato. I've heard many people say it differently. But a brew is if you are less than 1 year of age, you have a sudden, brief, now resolved episode with one or more of the following. So you're either pale or cyanotic, you have odd breathing, and you have change in tones, or either hyper or hypotonic, and you're not really responsive during that period. Usually lasts just briefly, 20 to 30 seconds, which seems a lot longer for most families. And they should be over, of course, by the time they come in. So if you are low risk, these patients, you can sort of assess them. You certainly can observe them in the emergency department. The problem with applying too much, it's a little bit nebulous in how to manage these because there's no great test, right? There's a lot of times we don't know why this happens. In the largest study of brew admissions, the most serious diagnoses that were ultimately made during the hospitalizations were non-accidental trauma and seizures. But truth is, the most common etiology is some sort of reflux issue. And by definition, brew is an unknown diagnosis, right? So if this event happened during feeding and they were choking, well, that actually was a choking episode. That isn't necessarily a brew. So that can kind of also empower you not to admit. But certainly be concerned in the younger kids. Like I had a 5-day-old the other day who had this event, and it was mom's, 4th child. So I was like, okay, that's, concerning. And this baby looked amazing, but I'm like, we're just gonna, watch you. I don't like the fact this first week of life, I'm probably gonna keep you, but let's just give you a chance. Let's see what's going on. We'll feed you all these things. Well, this baby had recurrent episodes of apnea and hypoxia. I'm like, okay, boom, done. We're definitely going to keep you. And that was like first presentation of then developed respiratory symptoms, but hadn't had any respiratory symptoms. And a lot of times apnea precedes URI symptoms in these young babies. And same thing for pertussis. Pertussis sometimes one of the first symptoms can be apnea. Without, and young neonates can't really generate that cough. They may not have other symptoms. So in a lot of the brew studies, people have looked at this. What are the high yield tests? And there's not really, a consistent test that we should order in all these kids. The 2 highest yield tests are pertussis test and EKG. That said, neither of which are very high yield in themselves. So here's a pathway that you can utilize if you find that helpful as well. The next is just not exposing kids to unnecessary cath urines. Avoid, if you have a child who's had a fever for less than 2 days, even if they don't necessarily have a source, you have a couple of days to get that information, right? You can treat that patient. If you treat that patient on day 1 of the UTI versus day 3 of the UTI, the outcomes are the same. So consider checking a urine for those kids at risk. Certainly, the young infants are at higher risk of UTIs, but if you have a a circumcised infant of any age, lower risk. Circumcised boy over 1 year, that's less than 1% risk. So only sort of be targeted in your treatment of evaluating the urine. We don't need to get x-rays for nursemaid's elbow. We talked about this in the radiology lecture as well. That's a clinical diagnosis, attempt to reduce it. As long as they are moving everything spontaneously, have no history of trauma, then that is a clinical diagnosis that you can intervene and treat, and you don't need imaging as any part of that. We talked about yesterday at length not using steroids in bronchiolitis. They don't impact outcomes and may prolong viral shedding. On the topic of avoiding imaging in kids, avoiding routine CT, abdomen and pelvis in trauma, there is a PCARN criteria that you can use to help decrease the risk. Again, observation is absolutely reasonable. The most common injuries in pediatrics is the solid organ injuries, so liver, spleen. Most of those are non-operative anyway, so use this criteria to encourage you to decrease scans. Remember that we have intranasal options for pain medications. You don't necessarily have to expose kids to painful IVs, and we please give kids medications, pain medications. Oral medications work too, but IN fentanyl is fantastic if you have a fracture. That helps with the process. API does happen. It's the most common abdominal emergencies overall in kids, but there are other things. Viral gastroenteritis, definitely a lot more common. Do a good exam, utilize additional scores to help you make that clinical diagnosis. I think Rav Singh's is the most helpful in sort of sorting things out. And then don't forget the power of reassessment. So sometimes kids, I'm like, I don't know, coming in for viral, vomiting, diarrhea, looks like a virus, but I'm like, I couldn't get a good exam on that kid. And remember, up to 1/3 of all appendicitis in kids do present with both vomiting and diarrhea, so can be sneaky. So have it on your radar. But reassess the kid. So sometimes I'm like, I want to take out that noise of the nausea and the pain, and I will give them Zofran and Tylenol, and then I'll reassess them. And that time really declares, okay, is this more likely an API or not? And giving patients good return instructions. So every vomiting diarrhea kid, I always show parents, I'm like, your appendix is right here. Please come back. This looks like a virus to me, but please come back if pain is worse, especially pain right here. Because sometimes early appendicitis, we miss it. Avoid unnecessary x-rays. Oh, ortho loves, man, I swear, they're like, okay, it's an elbow thing, please, x-ray the neck down to the fingers. They want every single x-ray and it has to be perfect. Yes, do a clinical exam because things are connected, but you don't have to get every single x-ray, and you can use this choosing wisely to push back on your consultants if that helps you. You don't need to routinely get pelvic radiographs in pediatric trauma, especially if they walked in. No need to get the pelvic x-ray. That gives you enough information. And next is avoid giving steroids to pharyngitis. And this, what's at the heart of this recommendation is that sometimes leukemia does present with sore throat. And unfortunately, if you give steroids to kids, that can, first of all, delay the diagnosis of leukemia, but second, it can actually kick them into a different treatment protocol that has a higher mortality rate. And ibuprofen works, for pain. It's just not worth it. So please avoid giving steroids to pharyngitis. And lastly, we all know this empowers you. If you've got a little focal abscess that you drain, you don't need oral antibiotics. Sure, maybe a little topical, that's fine if it's a little red and ugly, but we don't need oral antibiotics for this. And with that, thanks so much for your time.